Hey, I'm Megan Piffner, and welcome to Mornings with Megan. Grab your coffee and let's have a convo. Welcome back to Mornings with Megan. If you are joining us, go back and listen to part 1 of my conversation with Marlene first. It is so good, and it will make this land even more. For those of you who have been waiting, we are back, and we are getting into the good stuff. Last week, Marlene walked us through the pelvic floor, why so many women normalize symptoms they absolutely do not have to live with, and the shame that keeps so many of us from asking for help. Today, we are talking about what it actually looks like to walk into a pelvic floor therapy session for the first time, how to navigate insurance, the incredible advocacy work that Marlene is doing at the state level, and 3 things you can do for your pelvic floor this week. Marlene, welcome back. Like you were mentioning earlier, the doctors don't know that pelvic floor therapy exists.
Yeah.
You have a bunch of certifications in sexual health and intimacy, and it seems like trauma-focused care is really a core piece of the work that you do. How does that show up in your sessions with clients and how you're working with them?
It is the most integral part of my practice. Trauma-informed care, understanding nonverbal communication, body language, seeing what signs of distress somebody might be in is so important. It's one of the things that I make sure every one of my practitioners is well versed in, because I would say trauma and pelvic health are very interconnected in many ways. Doesn't mean it's always very big T trauma, something like sexual assault, which I do see a lot. It could be something like a religious upbringing, a parent that was like shaming about sex. There's all variations. It could be like somebody had an inappropriate relationship with a teacher at some point. There's so many variations of what trauma is and how it's stored in the body. And when we're working on the pelvic floor in pelvic health or on any part of anybody's body and touching their bodies, that can show up in very different ways. So it's sort of like without safety, without consent, without that foundation of I trust you and you trust me, and we have this mutual understanding, we can't really do any work. We can't do any meaningful work until that foundation has been established. And it looks different from session to session, I would say, just in terms of what language we're using. Some things that we always are really mindful of is the first time we evaluate somebody, even just touching their shoulders. Can I put my hands on you? If I touch somebody's shoulders and they flinch, I am not doing any internal assessment on them. I already know from the first few minutes of the session, I'm not going to ask to put my hands inside their body. That is something that I'm really clear about with my clinicians, is that if we touch somebody and their muscles tense and they're not feeling safety, we're going to modify the session. So we're just at every stage. Are their eyes darting off? Are they getting emotional? Emotional is fine, right? We see a lot of emotions come up here. We're not scared of any of it, but we just want to be mindful of what is the body's messaging? What is the body wanting us to do? Because a client can say, yes, 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 I want to do all the things today. And then their body is telling a different story. So we're really tuned in through that trauma-informed lens on what's appropriate, what's not appropriate. And then we're also checking in verbally, explicitly all the time.
So why don't you give us a little bit more information on what a session might look like? Because when I think of physical therapy or occupational therapy, I'm imagining a practitioner at a gym manipulating my knee or my shoulder and showing me exercises, having me do them so they can see how my body moves. What would a first session look like for someone who has never done pelvic floor therapy before?
I love this question because I do think it demystifies the appointment a lot. And had I known, I might have called earlier. Our sessions are 60 to 90 minutes. So you're here for a substantial amount of time. We talk a lot in that first session. It's really just information gathering. We're going over intake paperwork. We're talking about what's meaningful to you. What are your goals? What are you dealing with? Really in-depth health history. How long has this been going on? What have you done that's worked? What have you done that hasn't worked? What feels good in your body? What motivates you? How do you sleep? What do you eat during the day? What does a day-to-day routine look like for you? How are you managing stress? So really, really thorough. I'm sure you have something similar. Then once we get through the conversation, which is usually about half the session, we move into assessments and we do a breathing assessment. We do a postural assessment. We do a functional movement assessment. So what does it look like if you pick up a laundry basket? What does it look like if you pick up your child off the floor? How do you do a normal squat? How do you just, again, functionally, what are we seeing? And then we move into, is it okay if we do any body assessments today? That can look like abdominal wall assessments. If they're postpartum, we're doing a check for diastasis. We're looking at how are they integrating their core? Can they engage their deep core? What does that look like? Are they firing their glutes? Are they firing their core muscles? Then we move on to a pelvic floor assessment if and when appropriate. And what a pelvic floor assessment is looking externally at tissue, making sure that everything looks healthy. We're not seeing any redness, irritation, signs of infection, anything like that. And then we're gently touching the tissue externally just to assess if there's any numbness or pain externally on the vulva. I'm showing you this little picture here, just externally. So we're looking at some coordination patterns. And then the internal pelvic floor assessment, which again, when and if appropriate, is just one finger going into the vagina. And it's assessing 3 different layers of muscles in the pelvic floor. Coordination of the pelvic floor. Can we contract? Can we relax? Can we bear down? What happens when we cough? And then we're just assessing, does that feel okay? Are you connecting to it? Are we getting a contraction when we ask for a contraction? Are we getting somebody that doesn't know what a contraction is? So we're just looking at function and health of the tissues, coordination of the tissues, and then also just any points of discomfort, pain, numbness. And then we spend about 5 minutes at the end of each session. Just here's what we found. Here's what we think. Here's how we think we can help you. Do you have any questions? Moving forward, this is what we would recommend. It's always a collaborative conversation. Pelvic floor therapy can be very helpful if you have the time for it and you have the energy to invest in it. But we're not magicians. We're not going to wave a magic wand and you come one time and then everything is resolved. It does take work. It does take intentional exercising and breathing and lifestyle changes, just like with you too, with nutrition and looking at the body in that way. It is very much a collaborative teamwork. Hey, this is what I found. This is what I think we can help you with. Are you on board with that? Are you here to do the work?
I love a collaborative approach, and I feel like it gives women so much agency over their care, and to be able to have a practitioner see them, hear them, and say, okay, I'm going to meet you where you are, because I think so much of this 7-minute meeting is, here's the things that you can do. Here's a handout. Bye. See you in even if they get the handout, a lot of times there's not even a handout, and the handout may not be relevant to their life. If you can't pick up your child, then those exercises may not be relevant. So I love that your team and that you spend so much time with each individual client going over all of these things, going through what type of care they want or they need, and then meeting them where they are physically, mentally, emotionally, because that is such a big piece of this. Because as you said, even though they may verbally say to you, yes, I am ready for this, their body may not actually be ready for what is to come. And then there's that conversation with that internal versus external. And thank you so much for explaining that, because I think that does demystify. When I went to see a pelvic floor therapist, I didn't know that that's what was happening. And it was very shocking, very uncomfortable. And I think that part of that whole intake could have gone so much better if I had been prepared for what we were doing, why we were doing it, how this was relevant to health and all of the challenges that I was having, which no one talked about, because it's one of those shame things. So you don't really talk about as a young woman, especially having sexual health problems, pain with sex, etc. One of the things that I have heard you talk about are the challenges with getting pelvic floor therapy covered by insurance, which is one of the reasons that you left the insurance model when you opened the Lifted Lotus, and part of the advocacy work that you do. What is the access problem, and what do you want people to know about navigating insurance when it comes to pelvic floor therapy from an occupational therapist or a physical therapist?
So Insurance is a tricky one. And as you're talking, it's obvious that there's a system that's not working for a lot of people. 7-minute sessions is not okay. There is no healing work happening in 7 minutes. So I think that one of the reasons I left insurance model is because I wanted to spend time with people and I wanted them to have a quality hour or 90 minutes so that they weren't coming 3 times a week, because one visit a week is enough if they're getting the appropriate care. Nobody has time to go to an appointment, PT or OT, 3 times a week unless you're recovering from surgery. And it's just not realistic for life. So the most I ever see anybody is once a week. And even that is rare. I usually see people every other week, and they're getting such a dedicated time with me. And I send them home with a plan, and we're really communicating what that is so that they don't have to come as frequently. And the insurance model, because the sessions are only on average 20 to 40 minutes, they do actually require that they make appointments 2 to 3 days a week for many, many months. And I live in a different model than that. That's not what I would be able to do. That's not what I would want to ask of my clients. I'm cash-based clinic. So I want to see them as much as they need, but as least as I can so that they're not spending tons and tons of money out of pocket. I think just having that hour of time with somebody and giving them care for what their priorities are is so important to my model. And in insurance, they're not going to reimburse for painful sex because nobody cares about women's sexual wellness. They're not going to reimburse for birth trauma and maybe urinary leakage, but prolapse doesn't get reimbursed that much. There's all these things that in women's health, like painful sex, difficulty orgasming, that I see that are not billable. They're just not billable. No insurance company is going to look at a bill or a note that says client is experiencing painful sex and would like to achieve an orgasm. They don't care. The system in general is flawed, and it doesn't allow for long, lengthy, quality visits. That's why doctors are overwhelmed and they can't learn about pelvic health because they don't have time, and they're just still trying to get all their notes done and get all their reimbursements. So it was very intentional for me to go into private practice. But because I really care about access to care, I do a couple times a year offer a discounted rate for sessions because I do want greater access, and I do want people that don't have the money to afford it to be able to come in even for one session can be really helpful. I think just giving clients the language and the understanding and the anatomy of what's going on in their body can be really empowering. That teaching piece, that educational piece can be really helpful. So I think that was a long-winded insurance answer, but I think insurance is very helpful in many cases. And when we go back to what you were saying about your experience in pelvic floor therapy, I'm really sorry that you felt dismissed and that you felt like it wasn't communicated well. Not all clinicians and doctors are created equal. And it really sucks because it does mean you have to start that process again and build up that courage again, but keep trying. Ask questions to, send an email to a different practice and just ask what their protocol is and see if they explain things a little bit more clearly. And certainly there's such a high value for insurance-based clinics because that is what most people are using. So if the therapist isn't the right fit, go to another insurance-based clinic and try a different one because you will find one that's good.
You do some advocacy work through your position on the board at the New York State Occupational Therapy Association. What does that look like? I imagine it ties into a lot of the education that you just gave us here, but share more about that.
So I just really believe in giving this information to as many people as possible because I didn't have it 8 years ago, 10 years ago. And so at the state occupational therapy level, I also believe that occupational therapists really have a very unique skill set for pelvic health rehabilitation. So I'm just trying to spread the word to as many OTs as possible to let them know that this is a specialty that they can go into and demystify it again. Just what is it? How can you help? What are the populations? I happen to work in women's health or with vulva owners, but there's men's pelvic health, there's aging pelvic health, there's pediatric pelvic health, there's oncology pelvic health. There's so many avenues that you can go into this specialty. And I just believe in it so much for everyone. Every single person in the world would benefit from at least a session, that I just think giving other OTs the knowledge that this exists is really important to me. So it's just a lot of, it's online advocacy, it's quarterly meetings, teaching about pelvic health to other occupational therapists within New York State. And then at the national level, there's only 2 states currently in the United States that have legislative permission for occupational therapists to do pelvic health rehab. And it's California.
What?
Yes.
That's bananas.
It's bananas. So California was the first state to be passed. And then I helped write the paper that was presented to New York State, and it was passed last year. So California and New York are the 2 states in the United States that have legal permission for occupational therapists to do pelvic rehabilitation, which is like another really proud moment in my life as an occupational therapist, that I helped this position paper get passed.
That's huge. So does that mean that outside of California and New York, that occupational therapists are not able to do pelvic floor therapy?
They can, but there's not anything in writing at the legislative state level that says that they have permission. So
it's like a gray, one of those gray wiggly areas.
It's a very gray area. So that's another part of the advocacy, is getting other states to write these position papers for their organizations to get that same permission. I know.
Such important work that we still need this in 48 other states. That's bananas. I thank you for all of the work that you're doing and everything that you're bringing forward to the legislative process, to the New York State, and the women in general that you're helping. What are 3 things that you want every person listening to do for their pelvic floor this week?
Ooh, 3 things. I would say number 1 is slow down, drop into your body for just a few slow breaths and see if you can connect to your pelvic floor. I think everybody can do that. See if you feel the pelvic floor lengthening and kind of moving with the breath. Number 2, look up bladder and bowel health norms. I think that's really empowering. I have so many people that come in and they don't know if they pee every hour. They don't know that that's too frequent. So making sure that you know what's normal for healthy bladder control, healthy bowel control, so that you know if something is different, then you can get some support around it. And the 3rd thing, if you're a vulva owner, don't hover over toilets. It's not good for you. Just wipe the toilet seat off and sit and have a pee and let your pelvic floor relax.
Oh my gosh, you're speaking to my soul, because nothing makes me angrier than going to the women's room and I'm like, you all are being so rude. Stop it with this hovering thing.
Yeah.
So everyone this week.
Don't hover.
Don't hover first. Okay, so that's our thing. We're not hovering. We're going to actually sit down, relax, put your tush on the actual toilet. 2, we're going to look up bladder and bowel norm habits, so we understand how frequency matters, how many days a week, etc. Again, there is that big difference between common and normal, and so we're talking about normal, not common. And then 3, we're slowing down, taking a moment of pause, and getting some breath into our body. And I assume that this is for us to relax and let go of some of the tension that we probably are carrying around all day, every day, that is affecting our pelvic floor health. Marlene, it has been such a pleasure. Where can people find you and the Lifted Lotus?
So you can find me at lifted-lotus.com. That's our website. You can find me on Instagram at the Lifted Lotus, no spaces. And we are located, we have a brick and mortar space in Williamsburg, Brooklyn at 202 North 4th Street in between Driggs and Roebling. We would love any inquiries or feedback or any curiosities. We're here for you.
If anything that we talked about today landed for you, the leaking, pain with sex, prolapse, constipation, the shame piece, please hear this. You do not have to live with this. It is not normal. And as Marlene let us know, most of these things are addressable and preventable. Everything will be linked in our show notes. Until next week, friends, take care of yourself, and I'll see you next Wednesday morning. Can you do me a favor? If this episode gave you something to think about, share it with one woman in your life who needs a different story about perimenopause. Our bodies didn't come with a user manual, and this perimenopause thing can feel confusing and lonely. But you are not alone. You are not crazy, and you are definitely not broken. And maybe someone in your life needs that reminder today. Let's spread the word and be kind to each other and ourselves. Now the legal bit. I'm a nutritionist, but I'm not your nutritionist. This podcast is for information and education only. No client relationship is formed. Always seek medical advice when necessary. I'll see you next Wednesday morning.